Take it away.
Thank you so much, Dr. Gunby. So yes, everybody, I'm Mac. I'm a third-year resident. This talk was conceptualized on my flight back from Mexico. I got free internet on the Delta flight, and I decided to read the most recent ACP in the clinic periprocedural anticoagulation therapy thing. So I figured I would do this because it was very informative for me. So starting with disclosures, I don't really have any disclosures except for the fact that I have bridged somebody with heparin before. And here's a meme just to kind of summarize that. For our learning objectives today, by the end of the talk, you're going to be able to compare the pharmacology of familiar antithrombotic agents. You're going to summarize the factors contributing to thrombotic and periprocedural bleeding risks. You're going to be able to solve common periprocedural antithrombotic management problems. You're going to be able to contrast the timing of interruption, as well as see the benefits and drawbacks of bridging. You're going to be able to criticize the drawbacks of the available literature for periprocedural antithrombotic management. And then you're going to be able to design your own plans for your patients in both the outpatient and inpatient setting. So before we get into stuff, let's do a little bit of a pre-test. So here's our first question. So Cora Coag is a 74-year-old non-binary patient with a history of atrial fibrillation on apixaban who was admitted status post-fall with severe head trauma. They fell while gardening in their front yard. Their partner of 50 years found them pass out on the lawn and called 911. Interval head CT without contrast reveals an expanding subdural hematomas. What is the reversal agent for apixaban? And we don't have to get everybody. We can just get like generally enough people. All right. Great. What's this? Question 2. Warfarin is a 25-year-old trans man with history of left lower extremity DVT 5 months ago on Coumadin and prolonged QT syndrome presenting to clinic for perioperative management prior to AICD placement. He is doing well and just returned from Coachella. He doesn't remember much, but says the vibes were great. What should be done with his warfarin prior to his procedure? Continue warfarin through the procedure, test the INR 10 days before and hold the warfarin 2 days before, test 10 days before and hold the warfarin 5 days before, test 10 days before and day of procedure, and then hold warfarin 5 days before, or increase the warfarin dose 5 days before. You're welcome, Rainey. I was slaving over the names last night. Great. So a little bit more of a spread for these. Next question. Heparin is a 55-year-old trans woman with history of atrial fibrillation on apixaban and colon polyps 5 years ago, presenting to clinic for perioperative management of her anticoagulation prior to colonoscopy. She has 4 cats and is planning on adopting a bonded pair at Petco after the procedure. What should be done with her apixaban? Should we continue with the apixaban, increase the dose of apixaban, hold 2 days prior to colonoscopy without a heparin bridge, hold 2 days prior to colonoscopy with a bridge, or hold 5 days prior to colonoscopy with a bridge? That's not going to do it. Okay. 2 more questions. Ticagra Lori from Venice, 68-year-old patient with history of hypertension, hyperlipidemia, type 2 diabetes, CAD, had PCI 1 year ago with a stent, presenting to clinic 1 week prior to a scheduled CABG. They take aspirin, clopidogrel, olmesartan, atorvastatin, metformin, semaglutide. They watch the Kardashians. They haven't heard from their cardiologist or cardiothoracic surgeon and are hopeful their primary care doctor will answer all of their questions. They also want to talk about the most recent episode of Survivor, but know you're busy, so they have their phone prepped with their favorite scene. What should be done about their antiplatelet agents? Should you continue the aspirin and the clopidogrel? Should you hold the aspirin and clopidogrel 7 days prior to the CABG? Continue the aspirin and hold the clopidogrel 5 days before the CABG? Continue the aspirin and hold clopidogrel 2 days before the CABG? Or discontinue the aspirin, initiate apixaban, and then hold clopidogrel 3 to 5 days prior to CABG? Hopefully these questions have a bit more flavor than like a typical mix app question. I've liked a button for, I don't know. Yeah. All right, great. We got a spread here. All right, and then final question. Veni Embalanzi, also from Venice, a 76-year-old genderqueer patient with history of hypertension, hyperlipidemia, type 2 diabetes, HFpEF, 60% now, love that. Atrial fibrillation on apixaban, and a left MCA ischemic stroke a couple years ago, presenting to clinic for perioperative management prior to left hip replacement, so Zay can go water skiing again this summer, which I'm not sure is totally allowed after a hip replacement. They want to make sure everything goes well because her grandkids are visiting then, and they want to be at their best, aka they want to school them on the water skiing. So through shared decision making, what should be done with their anticoagulation? Continue apixaban, hold apixaban 1 day prior, 1 day prior to the procedure, no bridging. Hold 1 day prior to procedure with bridging, hold 2 days prior with no bridging, or hold 2 days prior with bridging. Kind of split there. Great. Thank you so much for taking our pretest. So here's our roadmap for talking about things today. We're going to go over a little background. The pharmacology, I'll give you a framework for how to think about these problems. We'll talk about thrombosis risk, procedural bleeding risk, interruption and timing, bridging, guidelines, and then take-home points. And I think, it's interesting. This is a question that we really are confronted with very, very frequently in the inpatient setting and the outpatient setting. And I don't think I've ever gotten a formal talk on it. And I've gotten these kind of half-baked ways to think about it. So I was really happy with having the opportunity to dive into this. So let's start with some background. You guys can just put this in the chat. For which conditions are people initiated on antithrombotic therapy? This is both anticoagulation and antiplatelet stuff. So you can just throw anything in the chat. We just had 5 questions with a bunch of different reasons. AFib, love that. Mechanical valves, recent orthosurgery, PE, great. So the big categories: AFib, valvular, non-valvular, venous and arterial thromboembolism, mechanical heart valves, CAD, post-PCI, peripheral vascular disease, and then post-stroke secondary care. How many patients are on anticoagulant therapy in the United States? This is excluding antiplatelet therapy. Just give me an estimate. Oh, wow, 2%. Oh, yeah, chill. So yeah, so there's a numbers kind of vary everywhere, but 6 to 8 million or around 2% of people in the United States are currently being treated with anticoagulant therapy. And like I said, this does not include antiplatelet agents. And then how many of those 6 to 8 million patients will undergo invasive procedures per year? 0.1%, 40%. So around 250,000 patients, I didn't convert this to 2%, somebody can do that if they want, receiving anticoagulant therapy will undergo invasive procedures which require attention and evaluation for proper periprocedural management. This is an area of ongoing research. There are many guideline recommendations, and unfortunately, a lot of them have low quality evidence, but we are getting there. So now let's talk about the pharmacology. This should be pretty quick, but the main groups that we're going to talk about are vitamin K antagonists, direct oral anticoagulants, heparin products, and then the antiplatelet agents. So starting with warfarin, this is a vitamin K antagonist. For different parts about it, so the peak effect actually happens at 5 days. And then the half-life is 40 hours. I think we've all seen this anecdotally with our patients, where when we give them warfarin, it takes a few days for the dose increase to take effect. And then when things are wearing off, it takes an even longer time for us to see that INR normalize. And then for the reversal agents, this is going to be vitamin K or prothrombin complex concentrate, PCC. That's super, super expensive blood product that we can give in the hospital. For vitamin K antagonist periprocedural implications, these have longer hold times. So typically 5 days is when you're going to hold them prior to a procedure. They may require some periprocedural INR monitoring. Bridging may be needed for the subtherapeutic period before and after. And then they need to be restarted sooner, 12 to 36 hours, due to like the slow onset. And this is in comparison to DOACs. Any questions on vitamin K antagonists before I move on to DOACs? Great. So for the DOACs, or the direct oral anticoagulants, we have 4 main ones that I'll talk about today. Do y'all know the mechanisms of action of the 2 main DOACs? I ask this because I'm sure it's probably like a boards question. Yeah, so 10A, so that's going to be rivaroxaban, apixaban, and edoxaban. But dabigatran is the separate one, which is the factor 2A inhibitor. Its peak effect happens in a couple hours, and it has a relatively long half-life. And the reversal agent for this one is adarucizumab. I think that's how you pronounce it. I've never used this one in-house, but I know we've always talked about whether or not to use it. Then moving on to rivaroxaban, again, it's the factor 10A inhibitor. Peak effect is, again, pretty short or pretty quick, 2 to 4 hours. The half-life is shorter, and dexanet alpha, or PCC, are the reversal agents. And I think apixaban and edoxaban have similar peak effects and half-lives. And then they have, for the 10A inhibitors, the andexanet alpha and PCC are the typical ones used. For DOAC periprocedural implications, these are great. They have shorter hold times before a procedure, 1 to 4 days, depending on some factors, which we'll talk about later. There's usually no periprocedural monitoring that's going to be going on, and no bridging is needed for a subtherapeutic period. And then you can actually restart them later after the procedure based off some evidence, and then also the fact that they just take effect really quickly. Any questions on DOACs before I move on to heparins? Great. So for heparins, the 3 main ones that I wanted to talk about were low molecular weight heparin, unfractionated heparin, and then fondaparinux. So for low molecular weight heparin, so this is an indirect factor 10A and 2A inhibitor via antithrombin. The peak effect is pretty quick, 20 to 30 minutes, and then the half-life is like 3 to 5 hours. Protamine is the reversal agent, which I think we're all aware of, but interestingly, only protamine only does around like 70% of the job for this. And this is in contrast to unfractionated heparin, which has a similar mechanism of action, a quicker, like instantaneous peak effect, which I think we see, when we start people on heparin, we give them a bolus. We know that they're anticoagulated. Hopefully we don't bolus them too much. But then protamine can give 100% reversal. And then fondaparinux is a different mechanism of action, which is a selective factor 10A inhibitor via antithrombin. And this has a longer half-life. And there's actually no approved reversal agent for this. There are some studies or some case reports, I think, of using recombinant factor 7A, but I didn't really go into it more. For periprocedural implications, these are great. They can be used for bridging. For monitoring for, low molecular weight heparin, it's not required, but unfractionated, we often do. The risk of hit is higher with unfractionated than it is with low molecular weight heparin. And then in kidney dysfunction, we're going to want to be using unfractionated over low molecular weight heparin. Here are the mechanisms of action for some of these. So we have the vitamin K antagonist, which is kind of affecting all over the coagulation cascade. And then we have rivaroxaban and apixaban, the 10A inhibitors, and then dabigatran, the 2A inhibitor. Hopefully you're all triggered by seeing this photo of the coagulation cascade, even those of you who are going into hemonc. Yeah, Renata's given me a big yes. I love that. I love that for all of us. Great. So antiplatelet agents are next. There are more of them, but these are the ones that I tried to take because I think they're the more commonly used. Aspirin. Do y'all remember the mechanism of aspirin? Yes, COX inhibitor. So irreversible, that's the important thing. Inhibition of COX. There's no real peak effect. Courtney Cox inhibition, yes. Love her. Half-life is 3 to 6 hours, but again, this is an irreversible inhibition. Once it's on the platelet, it is there for the lifespan of the platelet. Clopidogrel is the next antiplatelet. This is the irreversible P2Y12 inhibitor. The peak effect is 6 to 8 hours when you load them. This is a loading dose, 600 milligrams, and then the half-life is around 6 hours. And then Procedural, again, another irreversible P2Y12 inhibitor, and then 2 to 4 hours, a bit quicker for 60 milligrams, and then half-life similar. And then Ticagrelor, interestingly, is the reversible non-competitive P2Y12 inhibitor, 2 hours for peak effect. Great. So, and then here is a visual representation of the mechanisms of action for these. Aspirin going for COX. We're not going to talk about cilostazol or dipyridamol, dipyridamol, or whatever, however you say it. And then there's ticagrelor and clopidogrel there at the bottom at the P2Y12. All right. For antiplatelet periprocedural implications, you have to think about, what is the indication that they're on for their antiplatelet? What if it is like a PCI or stenting, these at less than 3 months, less than 6 months, greater than 12 months? What is the actual timing? Do they need to be on aspirin? Really? Do they really need to be on aspirin? You should be asking yourself that. And do they still need to be on dual antiplatelet therapy? So a lot of questions, more that I think antiplatelets pose to me in the clinical setting than I think some of the other ones. So for takeaways from pharmacology, just know that warfarin has a very long half-life. For the reversal agents, we have vitamin K and PCC for vitamin K antagonists. For the DOACs, there's idarosizumab for dabigatran and andexanet alpha and PCC for the other ones. Heparins is protamine. And then platelets with irreversible receptor activity depend on the platelet lifespan for effect. Great. So now let's talk about a framework. What is your framework when deciding what to do with periprocedural antithrombotic therapy? Do y'all have a framework? Do you think about a set of steps? What are the main categories of steps that you want to consider? I don't have one. Ask the proceduralist. Oh, this is beautiful. Great. So same, Adrian. So I'm always thinking about what is the type of antithrombotic? Yeah, how strong is the indication? How much blood loss? Great. So McKenna's starting to sort of delve into like the areas that we need to think about. So what kind of antithrombotic therapy are they on? The things that we just discussed. What are the thrombotic risks? What are the bleeding risks? both for the patient and for the procedure. And then are you going to interrupt therapy? Are you going to continue the therapy? Are you going to bridge? And then when do you want to resume? And so I apologize that I don't have like a really great mnemonic, but this is the best that I could come up with. We have memorized, I think, probably less exciting and dumber things before. And the more I've like started this over the last 5 days, the easier it's become to remember. So TPIB resume. And this is going to be thrombosis risk, procedural risk, interruption, bridging, and then obviously resuming or resumption. I recommend that you all just take either this slide or something else and make a dot phrase. So every time this question comes up, you can type in your dot phrase to key you into what you should be thinking about when you evaluate these patients so they get full thought. Great. So now let's go on to kind of the nuts and bolts of the talk, the thrombosis risk. So the question of perioperative thromboembolic risk and the frequency of the question arising in the perioperative period is illustrated pretty well in these 3 major atrial fibrillation studies. So we have RELY, ROCKET AF, and Aristotle. These are studies comparing dabigatran and warfarin, rivaroxaban, warfarin, and apixaban and warfarin. Thousands of procedures going on and interruptions in these trials. And I think it just goes to show that like a lot of these patients who are receiving anticoagulant therapy are also going to be getting interruptions. And so we need to be evaluating what's going on. So when we assess a patient's thromboembolic risk related to AFib, we should place it into 3 different groups. So low, moderate, and high. What tool or scoring system do you use to evaluate someone's thrombotic risk with AFib? CHADS, exactly. So CHADS, 2 VASC. I was going to draw a little vein on there, but I got lazy. And I'm not going to walk through the components of like the scoring system right now because we use it so frequently in the hospital and in the clinic, but you can calculate it yourself. So for the low and moderate risk categories, the CHADS-2 VASC score of 0 to 3 and 4 to 6 is like pretty straightforward. The high risk categories, people who are high risk to have a clot related to their AFib, is going to be a very high CHADS VASC or a slightly lower CHADS VASC with a prior arterial embolism, valvular AFib, so rheumatic heart disease, or a stroke within the last 3 months, which I think sort of goes along with the prior arterial thromboembolism. Next category that we're going to think about is mechanical heart valve risk. And so again, we have low, moderate, and high. For these folks, for the low risk group, people with a mechanical bileaflet aortic valve prosthesis without any other things like AFib or strokes, that's going to be a low risk for having a thrombosis. Moderate risk is going to be that same kind of valve, but you're going to have risk factors like atrial fibrillation, prior stroke or TIA, hypertension, diabetes, heart failure, and age greater than 75. And then for the high risk group, this is the thing to note. Any mitral valve prosthesis is going to make you a high thrombotic risk if you have a mechanical valve there. And then for aortic valves, if you have a caged ball valve or a tilting disc aortic valve prosthesis, that will also make you high risk. And then stroke within the last 6 months. This is a chart that's looking at the specific risk factors and then risk for arterial thromboembolism without anticoagulation. And so we can see the caged ball valves really have very high risks compared to the bileaflet. The tilting disc is just a tiny bit higher than the bileaflet. And then the position of the valve, like 22% per year without anticoagulation of a mitral, like that's like a lot to me to like have a clot. So that was a pretty, I mean, I'm sure it's related to positioning and then low flow states. And then aortic is 12%. And then time since placement, this is something I think we see clinically in a lot of other things. Highest risk when you're close to the procedure, and then more normalized risk once you get later on. The next category that we're going to talk about, again, is venous thromboembolism. Again, we have low, moderate, and high risk. For the low group, patients will have need, if they've had a venous thromboembolism, they are low risk if it's greater than a year. They are moderate risk if it's 3 to 12 months. If they've had recurrent VTEs, and then if they've had active cancer, and then non-severe thrombophilia, which we'll go through in a second. And then high risk is going to be VTE less than 3 months, even more so if it's less than 4 weeks. And then severe thrombophilia is like protein C and S deficiencies and APLS. Many patients are actually deferred for surgery until after the 4-week period, sometimes the 3-month period. And I think that sort of bridges into talking about filters. I'll briefly mention like the IVC filters, and they're used in the hyperacute period, which is like less than 3 to 4 weeks for venous thromboembolism, wherein the use of therapeutic anticoagulation is going to be delayed even more post-operatively. If they're greater than 4 weeks, they don't need an IVC filter for the surgery. The data, this is a whole thing, and I'm not going to talk about it for this. And so if y'all have any questions about it, please ask your local IR doc. So here's a table that kind of puts all of this information together. Again, walking through this, when you're evaluating thrombotic risk, you're thinking, are they low, moderate, or high? And then you're thinking about their AFib, mechanical heart valve, or their venous thromboembolism. And a lot of these naturally, the low to high, the progression makes a lot of sense. So you can either snap a picture of this or it's in pretty much every single guideline. And so for the takeaways, again, low, medium, high, AFib, mechanical heart valves, and VTE. And then I would just like kind of commit to memory for AFib, the high risk categories are going to have very high CHAS2 VASC, rheumatic heart disease, or recent stroke. Mechanical heart valves, mitral valve prostheses, the weird aortic valve prostheses, recent strokes, and then for VTE, something very, very recent or a severe thrombophilia. All right, any questions on this before I go to the next slide? Great. So then now let's talk about procedural bleeding risk. So procedural bleeding risk, again, is divided into 3 groups. It's going to be minimal, low/moderate, and high risk. And so I want to do some practice like estimating procedural risk. Can people put into the chat? So for a hip replacement, do you think that is a minimal, low/moderate, or a high bleeding risk procedure? High. Adrian, you're so smart. Ruth, you're so smart. What about cataract surgery? Low. This one's actually like minimal versus low. I actually think I should put minimal there. And then for colonoscopies, what do y'all think for colonoscopies? Yeah, great. So, oh, Lily, you're so smart. Everyone's smart here. Everyone's smart. Everyone gets a trophy, but like Lily's like a little bit. Lily gets like a gold trophy. So let's talk about it for each group. So for the minimal group, these distinctions are made based on 30-day bleeding risk. Minimal is defined as approximately a 0% risk in 30 days of bleeding. Examples of procedures labeled with this minimal risk are colonoscopies without polypectomies or without biopsies, cardiac device implantations, minor dental procedures, cataract surgeries, and then arthrocenteses. In many cases, the recommendations made by multiple guideline papers and groups are to not interrupt anticoagulation if it's a vitamin K antagonist or warfarin. DOACs are a bit easier because they're easier to stop and then start back up. There are various studies looking at bleeding risk with interruption and bridging for these, although they're not the highest quality of evidence. For low/moderate, this 30-day bleeding risk for these procedures is going to be 0 to 2%. Examples of these surgeries include intra-abdominal and thorax surgeries, femoral and radial coronary angiography, lap choles, and then non-minor dermatologic procedures. The general consensus is to interrupt anticoagulation during these procedures. And then for the high risk, 30-day bleeding risk is going to be greater than 2%. These types of surgeries include cardiac surgery, vascular surgery, neurologic surgery, urologic surgery, cancer surgeries, like big cancer surgeries. And then colonoscopies with polypectomies are also high risk. I think we've seen this a lot in like the ER. People can bleed quite a bit after a colonoscopy with polypectomy. May not need to come into the hospital. Yeah, isn't it a great like colonoscopy image? I think Renata had like a similar response when I sent her a text with it. And then major orthopedic surgeries and joint replacements also fall into this category. So again, here's a summarized table. I want you to think about for procedural bleeding risk, minimal, low/moderate, and high. Think about what is the 30-day bleeding risk, the types of procedures, and I would just reference this. I would look up the guidelines and references. Polypectomy is going to be for, the scissors are for polypectomy, Luke. And then the recommendations for minimal is that they may not require VKA interruption, but then for low, moderate, and high, you do want to interrupt them. So I think there's one more thing to talk about for bleeding risk, and that's the HAS-BLED score. So because patient factors also contribute to bleeding risk. It's not just the procedure being performed. The HAS-BLED score was developed with the Border study, which assessed perioperative outcomes in outpatients undergoing invasive cardiac procedures, things like caths, pacemaker implantation, cardiac surgery. Nearly all of these patients were on vitamin K antagonists, and they received bridging perioperatively. A HAS-BLED score greater than or 3 is most predictive of bleeding. And so here are the clinical characteristics that you can reference here. Just go to MD Calc, and then the HAS-BLED score, the bleeds per 100 patient years. So you see that score 3 is where things really start to tick up. So for takeaways for this part, risk is defined as bleeding within 30 days of the procedure. The categories are minimal, low, moderate, and high. Minimal risk may not require VKA interruption. And then here are the high risk surgeries. And then always think if their HAS-BLED is greater than 3, it's most predictive of bleeding for them. Any questions about these before we move on? Great. Now let's talk about interruption and timing. When thinking about the interruption of antithrombotic therapy, you should first ask yourself, what is the procedural bleeding risk? So we're going to go back to that: minimal, low, moderate, and high. And then you have to ask yourself, should I stop the therapy or should I continue the therapy? And so specifically for warfarin or vitamin K antagonists, I've already kind of beat this to death, but for a lot of minimal procedures, you can continue their warfarin therapy. Because we'll go into the data here in a second. And then for low and moderate and high, you're going to want to interrupt the therapy. To talk about specifically minimal risk and warfarin continuation, unfortunately, there are not that many studies looking at these things with DOACs right now, so that's why I can't speak to that. But in general, single tooth extractions or other minor dental procedures are typically well tolerated when continuing vitamin K antagonists. For folks with high bleeding risk and possibly more tooth extractions, you can definitely consider interrupting the therapy. There are different ways to mitigate this risk, and I think dentists and oral surgeons are very much going to do this. They can have patients use TXA mouthwash. You can also do intervention-specific things like giving additional sutures or doing TXA-soaked gauze during the procedure. Then there's cardiac device implantation. So the BRUISE trial is something that evaluated warfarin interruption with bridging versus just continuation. The primary outcome of clinically significant pocket hematomas was greater in the bridging group, and other trials have shown this as well. So it's really fine just to continue the vitamin K antagonists for these procedures, as long as somebody's not like at a super high bleeding risk otherwise. And then for minor ophthalmologic procedures like cataract surgery, glaucoma, diabetic retinopathy, these are all relatively avascular and can be done without interruption of anticoagulation. The evidence behind this is kind of interesting. There was a meta-analysis that looked at this and showed that continuing anticoagulation during ophthalmologic procedures actually increased bleeding risk, but it was mostly self-limited. And so I think that's why they recommend continuing, because stopping and continuing warfarin can really, or restarting warfarin can be a whole thing. I think a special thing to note for everybody is that any patient receiving retrobulbar anesthesia should more than likely be getting anticoagulation interruption, because if you get a retrobulbar hematoma, that can result in blindness. And so we don't want that for our patients. Okay, so for the logistics of these, before the procedure for warfarin, you're going to hold it 7 to 10 days, or you get the INR 7 to 10 days prior. Then you're going to usually hold it 5 days prior if the INR is within the range that you want it. If there's a higher bleeding risk, then you can check the INR on day 0 or day of the procedure. And if you can give some vitamin K if their INR is greater than 1.5. Bridge if you want. Bridge if indicated, not if you want. After the procedure, high bleeding risk, you're going to want to restart the vitamin K antagonist a little bit longer timeline away. Low to moderate is going to be shorter, and then minimal, you probably shouldn't have stopped it unless something else was kind of forcing you to do it. Here is a nice chart that sort of outlines this. So we see for minimal bleeding risk, we've just continued the warfarin throughout. For a low to moderate risk, 5 days before we hold, you can do bridging if you want, but it's a separate thing to see if you actually should. And then you can restart the warfarin usually 24 hours after the procedure. For the high bleeding risk, again, 5 days before, bridge if you want. Really, really think about that. And then warfarin can be started 12 to 36 hours after that. Any questions about vitamin K antagonist interruption? Great. So if we transition over to DOACs, where I told you the majority of the recommendations are to hold, we see this pattern here. I want you to focus in on the red circle. The majority of the recommendations here are to interrupt at days -2 and -1. And then I want you then to focus on the procedural bleeding risk. You'll see logically that lower moderate risk procedures have a shorter interruption time, so 1 day before the procedure, and then higher risk have a longer interruption time, so 2 days before. I would commit this to memory for a majority of them, 1 to 2 days, unless kidney dysfunction, which you see with dabigatran here, is going to be 4 days and 2 days. But in general, I think many more of our patients are going to be on apixaban and rivaroxaban these days. And then looking at post-procedure resumption for high bleeding risk, you can take a couple days to let somebody really achieve hemostasis. But if it's low to moderate, you can restart it after the procedure. Then for antiplatelet interruption, in general, the recommendation from multiple guidelines based on low or very low to moderate quality evidence is to continue aspirin, regardless of the procedure. Additionally, the thought right now is to hold P2Y12 inhibitors such as ticagrelor, clopidogrel, and prasugrel ranked 5 to 7 days before a procedure. So these are irreversible receptor blockers, and they all depend on the platelet lifespan before their effect has worn off. And so I think that's why they're saying the 5 to 7 days, and then aspirin also is going to be 7 days. There are some comments about, cangrelor, the reversible inhibitor, bridging with that, but I'm not going to discuss that. I think that sounds like a much more complicated situation for somebody who's exquisitely high risk. And I probably would ask a cardiologist at that point. So for interruption takeaways, consider continuation of VKA therapy for minimal procedures, and then the hold times 5 days before for VKA, and then DOACs 1 to 2 days, depending on the DOAC, and then the creatinine clearance. And then for antiplatelets, you're continuing aspirin for almost all procedures, and then you're going to hold the P2Y12 inhibitors 5 to 7 days before. So now let's quickly talk about bridging. So for VKA bridging, mechanical heart valves, the PERIOP 2 trial was a prospective double-blind randomized control trial, which had just over 1,400 patients. They used dalteparin for bridging for vitamin K antagonist interruption in patients with AFib or mechanical heart valves. They showed no significant difference in major thromboembolism or bleeding between the bridging and non-bridging groups. There was also a meta-analysis done by Segal et al. Of primarily non-randomized trials evaluating vitamin K antagonist interruption with heparin bridging for elective procedures. There was no difference in thrombotic risk, and bridging was actually associated with an increased risk of overall bleeding. So in a lot of the guidelines, they're generally recommending no bridging in these situations because there can be an increased bleeding risk. If somebody has an increased thrombotic risk, that is when you should be asking yourself, should I be bridging them? And I think this is a lot of the thing that we see on the inpatient side when we have folks who have lots of comorbidities. That increased thrombotic risk is going to push you towards bridging them. For AFib, we can go back to the PERIOP 2 trial, which had an AFib subgroup that had no significant difference between bridging and no bridging for major thromboembolism and bleeding. And then the BRIDGE trial was a randomized double-blind placebo-controlled trial with over 1,800 patients with people on AFib on warfarin. The primary outcomes, again, were arterial thromboembolism and major bleeding. There was no significant difference in the arterial thromboembolism, and bridging actually increased major bleeding risk. And then again, just to kind of drive this point home, the RELY trial, which we discussed earlier, had a sub-analysis that showed interrupted strategies. So when you stop the anticoagulation, followed by bridging. That increased major bleeding risk. And then there was a meta-analysis done of DOACs versus warfarin for periprocedural safety, showed that they were both safe. And then uninterrupted DOAC strategies had lower bleeding risk when compared to interrupted warfarin with bridging. So again, sounds like bridging is increasing our rates for bleeding. And so for people with AFib, for bridging, for VKA and DOACs, generally no bridging is recommended. Again, if there's a higher thrombotic risk, then you can bridge them. I would probably just talk with the patient about that. For venous thromboemboli, there are no RCTs that exist to address the efficacy and safety for vitamin K antagonist interruption with bridging. Only a few studies limited to retrospective case series have assessed perioperative DOAC management in patients with VTE. These are a couple studies that I found that the guidelines reference, McBain et al. This was a protocol-driven inception cohort study with over 700 patients who had VTE who were given bridging. There was no difference in recurrence of VTE, major bleeding, or mortality. They found that the strategy is more frequently given with acute or subacute versus chronic VTE, which I think makes sense. You recently had a clot. I don't want you to reclot. Let's bridge you. Clark et al., the second study, performed a retrospective cohort study, which looked at over 1,800 procedures in just over 1,100 patients with VTE. Bridging increased the bleeding risk. There was no significant difference in the rate of recurrent VTE. So in general, no bridging is recommended for people with venous thromboembolism. So here are the takeaways for this. So for bridging, consider not bridging patients with VKA or DOACs unless high thrombotic risk. And I would just reference the thrombotic risk chart. The recommendations made with predominantly low quality evidence. So understand the territory that you're in when you're talking about this with your patients. All right. And for our last bit, I just wanted to say, there are so many guidelines on these topics. I primarily was using the CHEST, the ACC, International Society on Thrombosis and Hemostasis. Choosing Wisely has a thing about warfarin. There's American College of Surgeons. There's like lots of different things that go in and look at this, and they all generally have kind of like the same, they arrive at the same points aside from like little deviations here and there. So depending on what's going on, take a look at the guidelines, but then based off of our guideline academic half day recently, be very wise when you're looking through them. So they also have these wonderful charts which you can reference, which I think just make it incredibly easy to make your decision. So with our last bit of time, let's go back to our questions. Javelle, would you be able to quickly put up polls for these?
Yep.
Yeah. So what is the reversal agent for apixaban? Great. So I think that one did better. Awesome. E is the correct answer. For this patient, 25-year-old who is on Coumadin, who is getting an AICD placement, what should be done with his warfarin prior to his procedure? Should we continue it, test the INR and hold it at some interval, or increase the warfarin? Great. So y'all had, I think, a kind of a similar spread here. The answer, I think, based off of the guidelines for cardiac device implantation for someone who has a low bleeding risk is actually going to be to continue the warfarin throughout the procedure. I see a lot of you clicking choice D, testing 10 days before, which is correct. Day of procedure for folks who are high bleeding risk and if the INR was elevated. And then it is correct if you're going to hold the warfarin to hold it 5 days before. I think if I was going to do this, I would probably have been between A and C. So again, this is one of those things, just kind of push yourself to think about, is it okay just to continue the warfarin? And then for question 3, our patient who is getting, has had a history of prior colon polyps, which have been snipped, and then is getting another colonoscopy. What should be done with her apixaban? So C, you're all are rock stars. Don't bridge. Don't bridge. Question 4, Ty, what is going to be done with their antiplatelets prior to cabbage? Great, rock stars, everybody. I think we were split between B and C before, but now we are good with C. And then last question for Venny, what are we going to do with their serial decision making and be done with their anticoagulation? Great. So D, so this is interesting. So you guys were split between D and E last time, and now the preference is to go to D. Actually, I would say that because this person has such an exquisitely high thrombotic risk based off of like their CHADS2 VASC, that I probably would talk with them about like maybe bridging. And so I think that's sort of where it comes down to is like, are you not going to bridge? Or are you going to bridge? I think this person might be somebody who we can consider bridging. But again, you'll probably talk about it's going to be attending dependent. It's not super clear with the data. So here are take-home points. There's summaries of all the different slides that I've already given you. What questions do you guys have? I may miss this, but does DAP interruption change if you're within a year of PCI? Maybe talking with the surgical team about holding off until they're 1 year post-PCI on the surgical need. Yeah, so I think, yeah, that person, I think that's sort of what I've seen is, I mean, people trying to hold off on doing a cabbage until like after 1 year out. I think our person in our vignette was 1 year out. And I think we've generally kept the aspirin going on the inpatient side, like when I've been on cards A, and then we hold the P2Y12 inhibitors 5 to 7 days before. Yeah, it's a good question. And I didn't talk too much about antiplatelet stuff because there's a lot to go over for anticoagulation. Any seniors who have done Jerry, remember if the surgeons were holding ASA for hip surgeries, I think they were holding it by month. Oh, Jerry, woof. When you decide to bridge, like in the last case, would that patient continue low molecular weight heparin post-op, then restart apixaban 2 days after? Yeah, I think that's probably what would be done. 2 days after, since it's a higher risk bleeding, and then bridging since they're a super high thrombotic risk because of their elevated CHADS2 VASC. No problem. And then just a shout out for the ACC has a managed anticoag app, which is great. You can plug in a lot of these different patient factors and it'll sort of give you a plan. And then a lot of the times just ask your pharmacist. The pharmacists are really, they do this stuff all the time. And so they have a good framework. But in general, your framework, TPIP or Zoom, love it. That should be the way that you think about these. All right. I'm over time. Sorry, Sarah and Jabel.
No, not at all. Thanks. That was awesome. Thanks everybody for joining this morning. Before you log off, just a quick reminder, the risk pool is depleted. Molly and the other inpatient chiefs wanted me to remind everybody to please turn your pagers on.